Um, welcome in person and online to the Inclusive Futures panel, where we'll be talking through effective approaches to enabling the equitable access of people with disabilities to sexual and reproductive health. Now, there have been some small changes to the panel. So my name is Lisa Morris, and I'll be moderating today. And I'm the Learning Advisor in the Inclusive Futures programme, and I sit in Sightsavers UK. Now, together, our panel is representing Inclusive Futures today, a UK aid-funded consortium made up of development and academic partners across 6 countries, where together we innovate and scale solutions to disability inclusion across education, livelihoods, media, and relevant today, health. We work in low and middle income countries and humanitarian contexts, and we also aim to generate learning, evidence, and research about what works for disability inclusion. A couple of quick notes on terminology in the panel today. We use the term SRH widely to include contraception services, but also the prevention of HIV and STDs, comprehensive sexuality education, antenatal childbirth and postnatal care, as well as much more. And we also use the term OPDs quite frequently, which means Organisations of Persons with Disability. We'll be taking questions at the end of the session, just in the room. Now, first, please let me set the scene before introducing our panelists. The panel today is grounded in the fact that sexual and reproductive health is a human right. The CRPD, the Convention on the Rights of Persons with Disabilities, in 2006 set out explicitly that people with disabilities have the right to retain their fertility on an equal basis as others, be provided the same range, quality, and standard of free or affordable healthcare, freely and responsibly decide the number and spacing of any children, and the right to age-appropriate information, education around their reproductive health. We also know the global commitment and shared responsibility for universal health coverage through SDG 3 to achieve good health and well-being for all, and SRH targets around gender equality and empowerment in SDG 5. And we know that you can't have universal health coverage if you are leaving anyone behind. So to deliver on these rights-based commitments, SRH programming needs to leave no one behind, and that includes being inclusive of people with disabilities. We know we have a long way to go, and there are gaps in good practice, which is why we're here today. So please let me introduce the panel of Inclusive Futures Consortium partners presenting experience and evidence about disability and SRH. So first we have Rebecca Martin. Rebecca Martin is Senior Technical Specialist with Social Development Direct, an organisation specialising in gender equality and social inclusion. SD Direct also run the Disability Inclusive Help Desk, Inclusion Help Desk. Then we have Lois Orta, so CEO and founder of Network of Disabled Women Nigeria. Welcome, Lois.
Thank you so much.
We also have Mahendra Bikram Sah, Project Coordinator with Health System Strengthening Programme, Humanity and Inclusion, Nepal. Welcome, Mahendra. And lastly, we have Dr. Joy Shuebu, Director of Programme Operations, Sightsavers, Nigeria. So, Rebecca, I'd like to start with you. The first challenge we often come up against with disability-inclusive SRH is that there are gaps in data and evidence. So in your research, can you please tell us what you've found?
Thanks, Lisa. Yes, so at the Disability Inclusion Help Desk, we conducted a review of the evidence base on factors affecting access to and uptake of SRHR for people with disabilities in low and middle income countries. We found that the evidence base has grown quite rapidly over the last decade and is about medium size now on FCDO's measurements. We looked firstly at countries with FP 2020 commitments and found the most evidence from countries like Ethiopia, Ghana, Nepal, Senegal, and Uganda. We also found that evidence was concentrated in different places. So, for instance, we found quite a lot of evidence on the challenges faced by women and girls with hearing impairments and gaps for other groups, particularly people with psychosocial disabilities and mental health conditions. The second aspect that our research looked at was the evidence base on good practice on increasing full, free and informed contraceptive choice for women and girls with disabilities. We found a lot more gaps there. Although there are organisations and projects working in this area, interventions tend not to be well evaluated or documented, and the learning wasn't captured and shared. Though this has been improving over the last couple of years, we put out an evidence digest yesterday, and that includes learning from programmes such as WISH and the Inclusive Futures projects that my colleagues will speak about later in the panel. And this is sort of exacerbated by a finding from DFID in 2017 that people with disabilities are largely invisible in M&E activities, which extends to family planning programming, which affects inclusion and also the data that we're getting out of those projects.
Thank you, Rebecca. And in that research, what did you find around the factors affecting access to and uptake of SRHR with people with disabilities?
Thank you. So we found that there were a range of different factors affecting access and uptake of SRHR, which we grouped in 4 main categories that you can see on the slide. Firstly, we have individual factors, which relates to the intersecting and compounding forms of discrimination and disadvantage that people face, and that differs depending on the type and severity of people's impairments, but also on other factors such as age, gender identity and sexual orientation, caste, migrant and refugee status, and other aspects of people's identity. We found here that adolescent girls face particularly severe barriers to SRHR. And secondly, we have environmental barriers, and these might be the barriers that people first think about when they think about barriers that people with disability face. Under this one, we have things like the physical barriers that people face, such as a lack of ramps at healthcare facilities and clinics, a lack of adjustable beds and accessible sanitation facilities. So here we found that in Nepal, there was a study of about 300 young people with visual, hearing and physical impairments who were asked about the accessibility of their local healthcare facility, and only about 40% said that they thought that was accessible and friendly for people with disabilities. That access issue is really exacerbated by long queues and waiting times at clinics and long journeys to and from. The accessibility of family planning messages is also important here. So that can be barriers faced by not having sign language interpretation or captions, or solely relying on radio messages, for instance. The third group of factors that came up a lot was attitudinal barriers. So, for instance, the perception that people with disabilities are asexual, or overprotective attitudes and a lack of communication from parents and caregivers. And those couple of factors led to withholding of information that people needed on the assumption that they wouldn't need it. We also found coming up issues of stigma, negative attitudes and discrimination from health workers themselves. And this is an important factor. In Uganda, for instance, a study of refugees with disabilities listed this as the most important factor about whether or not they would be deterred from going and accessing family planning services. This factor is also really important given the history and ongoing practice in some places of forced sterilisation for women and girls with disabilities. So it's important to address those negative attitudes and discrimination to ensure that there'll be full, uncoerced and informed consent. Here we also found that girls and young women with disabilities could be infantilised, disempowered and have their voice, choice and control taken away. Lastly, for this section, we looked at gender-based violence and particularly intimate partner violence, which can limit access to and uptake of family planning methods. And studies have found that women with disabilities are twice as likely as women without disabilities to be victims of rape, sexual abuse and intimate partner violence. The last factor that we looked at there is institutional barriers, which refers to things like national policies. So despite advances that have been made towards ratifying the Convention on the Rights of People with Disabilities. There's still a lack of guarantees and policies for people with disabilities to have equal right to health. A 2021 study also found that in 23 Commonwealth countries, consensual sexual activity with people with disabilities is criminalised, and in 25 Commonwealth countries, sexual assault laws use derogatory language to refer to people with disabilities. Other institutional factors include a lack of disaggregated data, a lack of technical expertise on including disability perspectives in family planning programs, a lack of confidentiality when communication support is needed, and high costs for people with disabilities in accessing these services. So it's important to note here that these barriers can differ depending on the types and severity of people's impairments, and also to note that people with disabilities aren't a homogenous group. So there's no one-size-fits-all approach that will work, but instead services and information needs to be tailored. And there was a study done in Addis Ababa, Ethiopia, that showed this well. They held discussion group sessions with people with a range of disabilities, a range of different impairment types, and they found that people with hearing impairments face communication barriers, including a lack of availability of sign language interpreters, and many had negative attitudes towards family planning that were partially caused by rumours and misconceptions around family planning methods. Whilst people with visual impairments face barriers caused by poor healthcare facility design and infrastructure and poor road conditions to and from health facilities. And then finally, people with intellectual disabilities face mistreatment from some healthcare workers and other staff at the facilities. Beyond this, it's also important to take an intersectional approach, so the needs of LBT women with disabilities might be different to migrant women with disabilities, and there'll be overlap between those as well.
Thank you so much, Rebecca. Going back to evidence gaps, what did you find evidence on good practice on increasing full, free and informed contraceptive choice for women and girls with disabilities? What good practice did you find?
Thank you. So yeah, we found that this was a real gap, even in high-income countries as well. So to illustrate that, there was a systematic review done in 2020 on interventions to promote SRHR for people with disabilities. And that systematic review identified nearly 400 studies on the SRHR needs, barriers and facilitators for people with disabilities, but only 18 studies of interventions and no interventions promoting access to family planning, contraception, maternal health services or safe abortion for people with disabilities. Despite that, there was some emerging evidence on best practice, and you'll hear more from the fellow panelists. But overall, given the multiple barriers that women and girls with disabilities face, the diversity of disability and the different contexts, most sources recommended a multi-component approach with a range of tailored approaches. So promising approaches included including women and girls with disabilities in the development of family planning policies and programs, in line with the principle of nothing about us without us from the disability rights movement, including actively partnering with organisations of people with disabilities. Other promising approaches included peer education to improve the awareness of people with disabilities on family planning methods and services, having tailored key awareness raising and educational messages in an array of accessible formats, addressing the attitudinal barriers from caregivers, communities and health workers, ensuring to engage family members on family planning interventions to get their buy-in and create an enabling environment to improve access and uptake. We also found that satellite services and sexuality education for people with disabilities could be effective, and that there's a need to collect data to improve planning and policy. And finally, ensuring that family planning services themselves are accessible.
Great, thank you. Lastly, Rebecca, did you identify any areas for further research?
We did, yeah. So we found that there was a lack of systematic examination of how interventions can best address intersecting inequalities such as disability, gender, age, race, ethnicity, and other aspects of people's identity. We also found a gap on barriers and good practice for people with psychosocial disabilities and mental health conditions, and also a lack of good practice in increasing access to family planning for women and girls with disabilities in humanitarian contexts, despite them being brought up as an important group across these sources. Thanks, Lisa.
Thank you so much. Now I'd like to pass over to Lois. As part of the Network of Disabled Women Nigeria, you've been involved in the planning and design of inclusive SRH programming. Can you tell us about the practical barriers people with disabilities experience in accessing their full sexual and reproductive health rights?
Yeah, there are many barriers faced by women and girls with disabilities in their day-to-day lives. One of them is infrastructural barrier. We have attitudinal barrier. We also have institutional barrier. It was mentioned by Rebecca during her presentation. Women and girls with disabilities are triple jeopardized. First, as a woman. Secondly, as a woman with disability. And lastly, from the society. Her rights are not given to her. Attention is not given to her. And so many things that are sidelined against women with disabilities. They are excluded. They are the most underrepresented in every sector, including health. And under health, we have gender-based violence, we have family planning, and we also have sexual reproductive rights. Women and girls with disabilities have the potentials, they have the gift, they have the talent to be productive, but the support and opportunity is not given to her. I mentioned 3 barriers earlier. Let me share an experience of my very good friend from Nigeria who uses a wheelchair. She was pregnant. She was attending antenatal successfully. Unfortunately, one day she went for antenatal. On her way back from the clinic, at the hospital premises, she fell off from the staircase from her wheelchair. And that was how she started bleeding. And she lost the pregnancy. That is the infrastructural barrier we're talking about. If that hospital had a ramp, she wouldn't have fell off from her wheelchair and from the staircase. This is a practical example and practical experience of what women and girls with disabilities face. Another one was during COVID-19. She has hearing impairment. She also went for her antenatal clinic. And announcement was made that due to COVID-19, they will not attend to any other patient except COVID-19 patients. But because she went alone, she didn't go with a sign language interpreter. Others that heard the announcement left the hall, but she kept sitting down for an hour. And when she got tired of sitting without being attended to, she went and asked a question by writing. What is happening? I've been here for hours and nobody attended to me. And the receptionist said an announcement was made that due to COVID-19, we cannot attend to any other patient except COVID-19 patients. She said, oh, I'm deaf. I didn't hear when the announcement was made. These are two practical experiences of women with disabilities accessing healthcare services. I think I've answered your question.
Lois, thank you. Yes, absolutely. Now, as part of the Network of Disabled Women Nigeria, you've been partnering with Sightsavers, with BBC Media Action and other OPDs during the planning stages especially of inclusive SRH programming. So how can OPDs be meaningfully engaged in all SRH programming?
Yes. Women and girls with disabilities have right to everything. They have right to access healthcare services, including contraceptives. So the idea is, whatever we are doing as an organization, as an institution, as a government, we need to include women with disabilities. If you are organizing an event on family planning, do you have representatives from the disability community? When you are setting up committee, do you have representatives of persons with disabilities? What about your project, your activities? Everything you're doing, your agenda, if you have 5 agenda in your organization, you need to include disability inclusion. Because it is our right. Article 6 of United Nations Convention on the Rights of Persons with Disabilities talks about women with disabilities. Article 16 talks about violence and abuse against women and girls with disabilities. Government and institutions need to involve persons with disabilities, especially women and girls with disabilities, in every stage of planning, from the beginning to the end, from the planning stage to the implementation stage. Don't just invite us to implement. Include us during policy formulation. Include us when you're planning for that project, that event. I follow the processes of coming here. This process started from November 2021, when we submitted abstracts. From submission of abstracts, there was evaluation and other processes of selection. And my abstract, through Sightsavers, through the help of Andre, we were able to get through. There were processes, and we followed through. This is what I'm talking about. Involve us from the beginning. It took over a year before we got to this stage of coming to Thailand for this international conference. It's the same process. We should follow due process, stage by stage. Include us in all the stages. Ask us questions. How do you want us to do it? Do you prefer it this way or the other way? So in everything we are doing, we should include the issues of persons with disabilities, particularly women and girls with disability, whom are often violated.
Lois, thank you so much. Yeah, my last question leads to that. Why is it important to engage with women-led OPDs or women leaders of OPDs?
Yeah, it's very significant, it's very important, and it is also key to engage organizations of persons with disabilities, particularly women-led organizations with disabilities, because they have a uniqueness, they have some peculiarities. They are special people that need to be given their rights accordingly. They say nothing for us without us, nothing about us without us. Include us. And they also say, leave no one behind. It's a very big slogan that passes the message to everyone, both funders, thinkers, and actors. We need to involve women with disabilities, because what my need is as a wheelchair user is different from a woman with hearing impairment. It's also different from a woman with albinism. It is different from a woman with Hansen disease. Our needs and challenges are different. So we should treat women and girls with disabilities with respect, with equal opportunity, and make sure everything we do, we include them, we engage them, we provide the platforms, the support, the opportunities, and the funding. Because poverty is another big challenge in the lives of women with disabilities. Most of us cannot access healthcare services due to poverty. So the peculiarities are different. They are special and they are unique. We need to have that at the back of our minds whenever we are planning. Thank you.
Lois, thank you so much. I'd like to pass over to Mahendra from Humanity and Inclusion Nepal. So you've been part of the Inclusive Futures program in Nepal, where there's a recently completed project around engaging youth with disabilities in SRH. Can you first tell us briefly about the context, the operational context in Nepal?
Yeah. Thank you, Lisa, and honorable audiences. Nepal data make 2 to 12% person with disability. Among them, 21.5% are young population. Yeah, and among this population, 36.5% are physical disabilities. And in Nepal, so much good policy instruments are there. Nepal ratified UNCRPD in 2010. Constitution itself protects right of people with disability, and so much act and sectoral ministries policy all has done good provision, respect of right of person with disability. When we go into reality in service level, there is huge gap. So policy environment is good, but service accessibility is not good. It is yet to develop. I'm saying that another thing, women and girls with disability are facing intersectional multiple let's say multiple problem, discrimination, especially discrimination. So for Nepal, I think it is a top agenda to act on.
Thank you, Mahendra. Now, based on your experience in the Inclusive Futures program, can you tell us what approaches worked well to improve access and information? about SRH.
Yes. Seeing this context, Inclusive Future program was conducted in Nepal, led by Humanity Inclusion and other 5 consortium members, and 2 were organization of person with disability. And actually implementing partner was organization of person with disability. And one baseline was carried out there, and 3 findings are interesting. Number one, only 7.4% young people are attending, using service. And women have little bit superior information against boys with disability. Women with disability has little bit more information comparing to the boys with disability. What they know more means contraceptive related thing and adolescent sexual reproductive related information. Girls has little bit more. And so far, women and young girls with disability concern, they have, as I already said, multiple and intersectional other problems are there. With this, let's say this basis and that operating environment, Inclusive Future program has done some approaches, multiple approaches, but they work together in synergy and give good anticipated result of increasing access and uptake of sexual reproductive health services and right through these approaches. Number 1 approach was targeting. We targeted 3 levels. Number 1, young people with disability. As I already said, 21.5% are young people. Number 2, we involve service providers. Yeah, service providers. And service provider, I mean the health facilities, other social service, social protection service outlets. Yeah, last never the least, the governing authority. Yeah, this. And next, it is inclusive targeting. And next was awareness raising, especially behavioral change, communication, media mobilization, and mobilization of after school club, and also involving community people, especially parents were taken as a gatekeeper, like this. And also some activities like International Disability Day celebration, International SRS Day celebration, like that, well-planned such activities give some sort of message dissemination wider in the operating environment. And last, never the other, not last, third one is, as Luis said, that why DPOs or OPDs are to be involved. We did both in service provider side and let's say right holder and duty bearer side. And for that, we DPOs has 2 functions, or OPD has 2 functions. One, they can influence, they can be a model in their community, and they can influence person with disability. As she already there are diverse group. And another, they can approach government, or especially local government. As there are provision, UNCRPD in nation-based long-term plan and different guideline act. With the help of this, they can approach to a decision maker and ask them to prioritize the issue of person of disabilities, young people with disabilities, and allocate resource and do participatory tracking of the result, like that. And otherwise, capacitating health service provider, not only health service provider, school nurses, health facility staff, a counseling worker, we train them. And they supported not only delivery of, let's say, clinical service, they also provided counseling service, and also they minimized their prejudiced idea, because by and large, they are the integral part of society. They have some prejudice towards a person with disability, young people with disability. They also, it is minimized. And another very interesting strategy, I say interesting because there we did audit, accessibility audit by a committee. Committee is commissioned by three representatives, one from local government, one from DPO, and one from program staff with disability. And they did audit, accessibility audit. Later on, they disseminate result, and they call all concerned people, and with this result and some reinforcement from DPOs, decision maker become quite convinced that to integrate local development plan these issues. And health, in also I forgot to share you, after school club is not only club of young people with disability. It is the club of young people with disability and without disability. And this gives safe space for them to discuss specific issue and young people's issue overall. They cannot talk sexual reproductive health related issue with parent, with teacher, but among them they can talk with them. And they can help peer to go and seek the service. This, I think these are the major thing. These are the major approach, I think. And I forgot to mention about the role of local government. Local government, as per the act and their working procedure, they are entitled to serve in area of person with disability. They want to serve, but they have, let's say, as you know, in our country is just federalized, and institution arrangement is new, and such condition, staff or government staff with good thinking may not be sufficient. At that time, facilitation support is necessary, and some policy re-education may be necessary. And with our project intervention, they make one special vulnerable, VFP, vulnerable focal point. They appoint one staff. He facilitated to issue the disability card, and government has arranged some social protection packages. As per that card, it is possible to distribute in social justice way. And these are the main approaches. They work together, and we assume that the accessibility and uptake of SRH in young population become possible.
Mahendra, thank you very much. Briefly, based on the Inclusive Futures experience, do you have any practical points or messages that people could take away?
Yeah, I have some point. Maybe you can, let's say, take away and adopt as per your context. And some are already raised by Rebecca and Luis. Number one is funding agency, their external development partner, and government, especially INGOs, should facilitate government to collect disability data so that their planning and monitoring will be possible on evidence base will be good for them. Number one. And number two, while designing social behavior change communication and social behavior intervention, always think, like Luis already said, inclusion, accessibility. maybe accessibility not only of physical accessibility, maybe other thing, yeah? That should be addressed in a package, yeah? And next thing, next thing, program designer or development partner should not be focused only in access, only in use. Also focus on accessibility. If we keep only focus on use, then there may be some sort of pressure for young women to select the contraceptive. In developing country, perhaps you know, academic people are here, the issue of contraceptive is made responsible for women only. That is not fair. So I think use and make good compatibility in use and accessibility. Yeah. And next, engagement of OPD, Luis already said, in an entire cycle, context analysis, design, implementation, monitoring, in every step of project cycle, I think DPOs or OPDs are to be engaged. Not only physical disability, there are diverse. In our country, as per our act, there are 10 types. Yeah? So all diversified person with disability and their representative organization has to be engaged. And also, we have to focus on very crucial and software thing. Like time and again we are saying multiple, intersectional, and diversity-wise, inclusion, accessibility, this thing should be well balanced in program. Sometimes to make it quite handy, we put so much numerical thing. It may not work sometimes. We have to put both quality and quantity thing in program. Saying this, these are the practical point. I think it will be covered later on by other.
Mahendra from Humanity and Inclusion Nepal, thank you very much. Now I'd like to hand over to my colleague, Dr. Joy Shuebu, Director of Operations and Planning, Site Savers Nigeria. After listening to the panel, Joy, with their range of evidence and experience, what stands out for you about the inclusion of people with disabilities and SRH?
All right, thank you very much, Lisa. And for the benefit of those who just joined, we're talking about how to promote equitable access to family planning services and by extension, sexual reproductive health services for persons with disability. And I think yesterday it came out strongly at the opening ceremony that we cannot talk about universal health coverage without talking about family planning. But I dare say we cannot talk about universal health coverage without talking about inclusive family planning, because we cannot be seen leaving anyone behind. And just listening to my colleagues on the panel, I think it's safe to say that there is evidence that there are gaps that exist and barriers that are particular to reaching persons with disability with the reproductive health services that they need, which is a right that they have as human beings. So Lois has talked about the need to engage organizations of persons with disabilities because they are the ones that know where it hurts most and are able to provide guidance and direction to service providers and policymakers on how to make sexual reproductive health services inclusive of persons with disability. And Mahendra has shared with us very practical interventions that have happened in Nepal as regards to conducting accessibility audits of health facilities to see that they are actually welcoming for persons with disability, providing capacity building for healthcare providers so that they know how to provide these kinds of services to persons with disability, and also trying to influence the policy environment so that it is favorable for persons with disability to be able to access services. And I'll share with you an example of how this is possible. Currently, Sightsavers and BBC Media Action are leading on a project in Nigeria, which is called the Inclusive Family Planning Project. It is located in the northern part of Nigeria, where the need is highest for sexual reproductive health services, and it's focusing on increasing access to family planning services for girls and women alongside men who have disabilities who need those services. And so the Inclusive Futures program generally focuses on consortium type working. So we work with several partners. We work with development partners, we work with the media, we work with the academia, because we're also trying to generate evidence so that it can be used in other places. So for this particular inclusive family planning project in Nigeria, at the governance level, we have organizations of persons with disabilities represented. We also have the National Primary Healthcare Development Agency, the health systems of the government, who make decisions as regards to supplies for contraceptives and family planning services, represented at that governance structure of this program. We have our colleagues from the academia who are looking at the research part of it to see whether these interventions can really work and whether they are practicable to work in anywhere where these needs are. We also have BBC Media Action, because if you notice from Rebecca's presentation, the attitudinal barriers are much more, and they cut across the infrastructural, the attitudinal, the environmental barriers that persons with disability face. And so we feel that the media has a major role to play, and BBC Media Action is working with us and leading on that front, using the media to address some of the gaps as regards to awareness and education, as regards access to family planning services. They are also working alongside with persons with disability. They are hearing their stories and crafting and scripting messaging so that it will help address some of those barriers that persons with disability face. So we're using several social behavior change communication strategies, one of which is radio drama that seeks to address some of the things that people with disabilities face and what the society, the policymakers, and even persons with disability themselves can do to ensure that they increase their access to family planning services and sexual reproductive health services. And we try to engage all of the stakeholders, because for an issue that is multifactorial, you know that you need a multifactorial approach to be able to address this. And so the Inclusive Family Planning Project that we're implementing currently seeks to conduct accessibility audits. And usually the accessibility audits of these healthcare facilities are conducted along with the policymakers and organizations of persons with disability. Because if you want to influence policy and you want the voices of persons with disability to be heard, you need to put them in the same room so that they can speak to each other, which is what we are doing. So collaboratively, they go and make these assessments, they come out with recommendations, they sit on the table and decide how best to address some of these structural barriers. We also involve organizations of persons with disability in providing training and capacity building for healthcare workers to say, you know, this is how we want to be treated when we come to access family planning services. And if you want to make a health facility favorable for us, these are the things that will be required. This is what we can do to help. So sometimes we provide even sign languaging training so that the healthcare workers understand basic sign language that they can use to provide care for persons with disability that come to their facility. We are also providing capacity building for organizations of persons with disability, because we believe that they are better placed to raise their voices together and advocate for their rights. So we provide advocacy training for organizations of persons with disability so that they can engage with the policymakers and have their voices heard as well. And so you find that all of these pieces are working together to make sure that we're getting out the right messages and ensuring that we're looking at the cultural context as well. The barriers exist, but they exist in different forms. And like Lois had mentioned, even among persons with disability, there are peculiarities that exist. So you want to make sure that people with psychosocial disabilities are not left behind. They have their own peculiar needs, and that everyone is inclusive. And all the services we're providing, be it family planning service or whatever form of sexual reproductive health services, are inclusive of persons with disability. So in this program, when we started out, we brought together representation of women with all forms of disability, and we said to them, what are some of the major things that you think we should focus on? What are the age groups that you think we should focus on? And it was very clear that adolescent girls especially needed to be equipped with family planning services and sexual reproductive health services in terms of education, in terms of knowing their rights, and in terms of the autonomy that they have also in making those choices. And so we went ahead, and BBC Media Action led on informative research, and they held focus group discussions at communities having different age groups of persons with disability, just listening to the conversations as to what barriers they were facing in their context and the things that they feel will work in their context if they are addressed, so that we can increase the need and make available services for them as is required. And there's lots of stories came out from that research. We found out that as regards to reproductive health services for persons with disability, many times they are not the only ones making those decisions. Their caregivers and family members also have a part to play in making those decisions. So what that means is whatever interventions we're promoting that will improve equity regarding persons with disability, it has to also target not only persons with disability, not only the policymakers, not only the service providers, but the community and the families of persons with disability as well. Because sometimes in wanting to protect them, they feel that they are the ones who are better placed to make decisions for these people, and they forget that these people are capable of making decisions for themselves. And we feel that if we provide them the right information, they're able to make those decisions themselves. We have recognized that institutions and policymakers, healthcare providers, really want to make family planning services and sexual reproductive health care services inclusive. But the major gap is they lack the technical expertise to do that. And so sometimes people feel overwhelmed and they just, push it aside, and they feel, we can just provide for those that we're able to. We feel that it is possible to make family planning services inclusive of persons with disability. We think that sexual reproductive health services is a right for persons with disability, and we need a lot more of research. We need a lot more of documentation of good practices that work. And just listening to my colleague talk about what is happening in Nepal, I realized that irrespective of the contextual differences, there are strategies that work. And those strategies start with generating evidence from what has been researched as barriers, and engaging the right people, in the right place to talk about the issues and addressing them. So it is possible to have another world that is inclusive of persons with disability. But we need to have the courage to start the right conversations with the right people. And I believe that it will be possible for us to not just provide family planning for all, but inclusive family planning for all persons who require those services. Thank you, Lisa.
Okay, Dr. Joy, thank you so much. And thank you to all the panelists. We have about 15 minutes, so it would be great to take some questions from the audience. Perhaps we take 2 or 3 at one time. If you'd like to introduce yourself ahead of your question, and if it's directed to a specific panelist, then please also say so. I don't know if we can have any support with microphones. Thank you. Great.
Thank you very much. My name is Nambuba Sheri. I'm from Uganda. I'm part of HI, Humanity and Inclusion. I'm one of the beneficiaries of Humanity and Inclusion. And I just want to ask, when I came in, what is Rebecca? Somebody who talked about somebody falling off the staircases. And then my sister from Site Savers. Yes, we are saying that infrastructural barriers, we are looking at ramps. We shall keep on saying ramps, 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 but in the actual sense, they're going to give us the ramps, but they're not on a standardized measurement. They're going to give us a hill that is smooth. You can't go up, you can't go down. So it also becomes useless. So anyway, when we are trying to say we need the ramp, we must look at the standardized measurements. Second, we must have also train our nurses or health workers in these facilities we go, that they at least have the basics of sign language, that they're able to discuss or interpret or talk to our friends with the hearing impairment. And then also we have to have adjustable beds so that our mothers, us the mothers with disabilities, we're able to climb the bed easily and come down easily. Other than putting should I call it a box or what? A stair that you can climb and then get to the bed, which also gets very dangerous. That if a mother comes off that staircase, they can break and get another disability. So I pray that all of us who are advocating for SRHR services for mothers with disabilities, please, I pray, we ask our government, we ask our implementing policy makers, we ask anybody in our countries who is responsible to see that we get delivery adjustable beds for mothers. We avoid mothers dying at the traditional birth attendance places. Thank you.
Thank you so much for that comment. Yeah.
Thank you. I'm Frederick Msigala from Tanzania. Thank you very much for a very good and wonderful presentations. I just wanted to get an experience from Louis, but also from Rebecca from your study. Communication barrier, as I mentioned, is one of the challenges, particularly for deaf people when it comes to sign language interpretation. And I know to have a sign language interpretation in my country is very expensive, that deaf people cannot afford. In your country, Louis, or Rebecca, in your study, have you can you share some experience whether the government is ready to hire sign language interpreters to be in the health facilities so that they are able to provide these services when it is needed? I have an example. It's the practical example that you shared, Louis. In my country, and I have a friend of mine, a lady in her first delivery. When she was going to attend an antenatal clinic, she used to go with her mother. But during the day of the delivery, her mother was restricted to go to the ward. And he was attended by a male doctor, young one, and because of that lack of communication, that friend of mine could not be able to communicate with the doctor. He was told to do this and he couldn't do that. And she ended losing the baby because of communication barrier. I don't know now in your country, even from other participants, attendees, if you have a good example where the government has invested to ensure sign language interpretation is available. I agree with all the barriers that you have mentioned, that they are real a hindrance for persons with disabilities to access sexual reproductive health and family planning services. But as for now, I would like to get experience on communication. Thank you.
Thank you so much, Freddie. Perhaps we take, there's two hands up. So perhaps we take Innocent and then behind, and then we'll come back to the panel.
There's another hand behind.
Oh, so sorry.
Thank you very much. And I appreciate the panelists. I want to express appreciation to site savers. Doctor here, while she was making her presentation, she made specific mention of caregivers and training programs for them so as to effectively and efficiently care for persons with disabilities and also make decisions on their behalf. This is the first time I have heard that. I am a full-time caregiver for a person with disability. I have never attended any training program or any project on caregivers for persons with disabilities. The little I know is practical experience on the job. The little I know is training myself, reading, going on internet, trying to gather materials on how I can go about that. So, Doctor, I'm most grateful to you. And I want to plead with you, it's a passionate request. If your organization can give it prominence and maybe organize one for caregivers for persons with disabilities. Thank you so much. My second question is interrelated with the first. When the Madam President of Women with Disabilities, President of Network of Women with Disabilities, when she was making her presentation, she continuously mentioned women and girls with disabilities. How about boys and men with disabilities? Don't they deserve to have adequate knowledge of family planning and sexual reproductive rights services? And if they don't, how do they relate with their spouses or girlfriends and lovers with disabilities? You know, in some cultures, men take decision on whether or not the wife should adopt family planning and the type of family planning. And so if we don't involve the men in the idea of family planning, I doubt if we will make good success with inclusive family planning. Thank you so much.
Thank you very much. One more question and then I'll summarize and we can come back to the panel.
Thank you. So thank you also for your very interesting presentations. I'm Janemiek Evelo. I'm the Executive Director of Choice for Youth and Sexuality. And we work a lot with Dutch Youth Ambassador for SRHR. And one of the focus topics of this year's Youth Ambassador is inclusive comprehensive sexuality education, and especially also for young people with disabilities. So I'm curious to learn from you, from your perspective, what is needed to make comprehensive sexuality education inclusive for young people with a disability.
Great. Thank you so much for those rich comments and questions. I'll do a quick summary. Any comments from the panel around accessibility and standardized measurements? Any comments from the panel around communication barriers or good examples of government hiring practices? Any examples from the panel, particularly around the inclusion of boys and men in these trainings, and any examples or what is needed around inclusive sexuality education? That's a very top-line summary. I know that I didn't include everything. Maybe, should we start at this end, or is there anyone who'd like to respond? Yeah, Lois, I can see you coming in, please.
Yes, let me answer the question from my brother from Tanzania on communication barrier. In my country, we have a Nigerian Disability Act, which was signed into law in 2019. And according to World Bank report, we have over 20 million citizens with disabilities in Nigeria. Having said that, the Disability Act also provided an opportunity for the establishment of National Commission for Persons with Disabilities, which is already in existence, headed by the Executive Secretary, Honorable James Lalu, who is hearing impaired. Just recently, he launched a project on engagement of sign language interpreters who are going to be placed at strategic places in the MDS, agencies, and ministries in Nigeria. That's one action I know, and I'm also impressed with that. Then secondly, there is Deaf Resource Center in Nigeria, headed by Timothy Tinat, who trains those that are passionate on becoming sign language interpreters. And he also run and manage sign language interpreters in Nigeria. For persons with disabilities who are hearing impaired, they find it difficult to go to places with their personal sign language interpreter because they cannot afford the payment of that services. This is one of the services we're talking about. We have lost lives. We have experienced some bad moments due to lack of services that include persons with disabilities. So communication barrier is a big issue in the disability community. So the way you faced in Tanzania, that's the same way Nigerians with disabilities, especially those with hearing impairment, are facing. Thank you.
Lois, thank you so much. I think we have time for one more comment. Mahendra, I can see you're coming in, and then we'll wrap up.
I'd like to respond a little bit about your question and my country's practice regarding sign language interpreter. A discussion is going on. First, dictionary about, let's say, in American dictionary of sign language, there are 46,000 words. But in Nepal, only 50 to 100 words dictionary is made. And number one, that should be done by academia and language body. Yeah? And person working in INGOs, NGOs, DPOs, we are convinced our government. Recently, I am happy that a tripartite agreement happened to deploy one sign language interpreter in Ministry of Women, Children, and Senior Citizens. And there are some independent sign language interpreter. So my idea will be not one single way. We have to design different modality as per our context. So it is a common agenda for all who we are working for person with disability. I hope it will be also applicable for other things. Your question, actually, there is myth, there is a predetermined idea that sexual people with disability are either asexual or hypersexual. Yeah. So I think it can be resolved through re-educating health worker, doctor, nurse, health worker. Maybe sign language tasks may be heavy for them because they have limited time in developing country. Maybe some sort of prejudiced idea can be clarified if we strategically design training package for health worker, counseling person, and school nurses. First, maybe disability right literacy model, maybe inclusion, accessibility, type of disability, etc. Yeah, and then another maybe communication, how to communicate with as per diversity of person with disability, and other service-related skill and knowledge. So my idea will be, yes, we are already that type of training package, but it should be not conventional training package like a medical college. It should be rich, I think. Then even sex and sexuality issue can be little bit resolved by health worker.
Yeah.
Thank you.
So maybe just to add, my card is here. So if you want to reach out to us, it will be good for us to just have that conversation. But you need to get the right people in the right room. Listen to the people with disability themselves. That's the first step to getting to an inclusive, comprehensive sexual reproductive health service point of view. And then for the issue of the sign language interpreters, government can do just so much. You know, so it's not realistic for the government to employ sign language interpreters. We understand that. We're happy that the government of Nigeria at least is making some steps towards that. But as a program, what we have done is also to produce a model that consists of a training package for basic sign language for healthcare workers. We think that it is much more sustainable to saturate the health system with health workers who at least understand basic sign languaging. So that's one of the ways we're trying to address that. And to also further make sure that when we say build ramps, the people are doing the right thing. We brought together a group of engineers in Nigeria, including engineers with disability, and they looked at the standard disability accessibility audit. So we have developed a manual that says if you want to build a ramp, this is the measurement to make. If you want to make a building accessible, this is what it means, so that people don't just go away and do things based on what they think. As regards to male involvement, unfortunately, we have only one man on the panel. But when it comes to issues of family planning, the focus and the spotlight is usually on women for obvious reasons. But of course, in the project that we're also implementing, we're also focusing on boys and men, but the spotlight is on women and girls because they are the ones who have the most need for family planning services. So we're not also excluding them. They're also inclusive of our services. Thank you.
Okay, I think with respect to everyone's time, I'll wrap up here. So just a reminder that all these panelists are consortium partners in the UK aid-funded Inclusive Futures project. We still have a few more years to go in the project, and we will continue to produce and share learning, research and evidence about what works, what doesn't, and why in the area of disability inclusion. So it just remains to be said a big thank you to our panelists, our audience in person and online, as well as our host, ICFP 2022. Please do visit our resource hub under inclusiveFutures.org/SRHR or chat to us outside now. Thank you, everybody, and thank you.